Welcome back, Focus Learners, to today's Explainer. We're diving into the incredibly intricate, frankly fascinating science of drug hypersensitivity. But more specifically, we're looking at the life-saving medical protocols known as rapid drug desensitization. We're going to explore exactly how modern medicine manages to literally hack the human immune system, allowing us to deliver essential therapies to the very patients whose bodies are hardwired to reject them.
So picture this high-stakes clinical dilemma. A patient with a severe malignancy or maybe a life-threatening infection desperately needs a first-line drug therapy. But there is a massive catch. Their immune system recognizes that exact drug as a deadly threat. Giving them the medication could trigger anaphylaxis and total cardiovascular collapse. It's essentially a ticking time bomb inside the patient's body. What do you actually do when the cure could kill the patient before the disease even does?
Okay, let's dive into this. We're going to cover the drug allergy dilemma, phenotypes, endotypes, and biomarkers, how we hack the immune system, multi-bag desensitization protocols, managing breakthrough reactions, and finally, strict desensitization contraindications.
Starting with Section 1, the drug allergy dilemma, a high-stakes barrier. Drug allergy is this rapidly rising global issue, which makes sense since worldwide medication usage is going up and our targeted therapies are getting more complex. To put the sheer scale of this problem into perspective, 10 to 20% of the world's healthcare-engaged population claims to have a penicillin allergy. That is a staggering number of people. And for patients who are truly allergic, avoiding these offending medications has this terrible cascading effect. It means they have to turn to less effective, usually way more expensive second-line therapies, and crucially, it limits the availability of truly life-saving treatments for malignancies, chronic inflammatory diseases, and severe infections. Which brings us to Section 2. Phenotypes, endotypes, and biomarkers, identifying the wires. Now, what's really interesting here is how we figure out what we're dealing with. If you're diffusing a bomb, you need to know exactly which wire to cut, right? We do this by mapping visible symptoms, the phenotypes, to invisible cellular drivers, the endotypes. On one hand, we've got acute type 1 reactions. Those are driven by mast cells and basophils. On the other hand, we have cytokine release reactions, or CRRs, which are driven by immune cell activation and usually show up as fever, chills, and pain. And yeah, sometimes patients get hit with mixed reactions, exhibiting features of both type 1 and CRRs at the exact same time. Identifying which mechanism is at play is absolutely crucial for knowing how to diffuse it.
To track down these wires, clinicians look for specific biomarkers. In type 1 and mixed reactions, the key biomarker is serum tryptase. Think of elevated tryptase as the verifiable footprint left behind by an explosive anaphylactic event inside the body. It's an enzyme released directly from the granules of mast cells and basophils during a reaction. When levels spike above the normal range of 11.4 nanograms per milliliter, or more than 1.6 times a patient's established baseline within the few hours of symptoms, the medical team knows exactly which cellular pathway has just been triggered.
Moving on to Section 3, hacking the immune system, the cellular mechanism. Once the bomb squad knows exactly what type of reaction they're dealing with, they deploy a highly specialized medical intervention, drug desensitization. Now, to be clear, this is not a cure. It's a clever, deliberate, but temporary cellular hack used to diffuse those mast cells and basophils by taking advantage of the immune system's own inhibitory pathways. It starts in Step 1 with the rapid delivery of incredibly small, sub-threshold doses of the drug. Step 2 is where the magic actually happens. These low doses recruit enzymes called phosphatases right to the IgE receptors on the surface of those mast cells and basophils. Finally, in Step 3, these phosphatases act as a massive biochemical roadblock, completely blocking signal transduction. The cells are essentially blinded to the allergen, which prevents the release of explosive mediators like histamine and tryptase.
Let's look at how this is done in practice in Section 4. Multi-bag desensitization protocols, the manuals.
To achieve this cellular block without just guessing dosages, clinicians rely on highly standardized manuals. The most common framework is the 3-bag 12-step protocol. It literally uses 3 separate IV bags, one at a 100th concentration, one at a 1/10th concentration, and then one completely undiluted bag of the target medication. They administer the drug in 12 sequential steps, doubling the dose every 15 minutes. This safely gets them to the full therapeutic target in about 5.7 hours. But for patients who have had severe initial anaphylactic reactions or who have major comorbidities, there's an even safer route, the 4-bag 16-step protocol, which begins at an incredibly dilute 1/1000th concentration. These carefully timed steps systematically build up a temporary state of tolerance.
Now, what happens if things go wrong? Section 5. Managing breakthrough reactions, handling the sparks. Before we get into the risks, I want you to check out this absolutely incredible number, 99%. Despite the obvious inherent dangers of reintroducing an allergen directly into a patient's body, 99% of these desensitization protocols are successfully completed. Furthermore, across thousands of documented cases covering antibiotics, chemotherapies, and monoclonal antibodies, there have been 0 reported deaths due to drug desensitization. Literally 0.
That said, breakthrough reactions, or BTRs, definitely do happen. You'll see them in about 10 to 30% of protocols. When they do happen, symptoms are typically mild and mirror the patient's initial allergic reaction. The vital takeaway here is that a breakthrough reaction does not mean the desensitization failed. It just means the medical team has to pause and provide vigilant, symptom-specific management. If a reaction does get severe, they immediately deploy epinephrine. Clinicians are also always on high alert for patients with comorbidities like cystic fibrosis, acute cardiac disease, or anyone on beta blockers, because those definitely increase the risk profile if a BTR happens.
Finally, Section 6, strict desensitization contraindications, the red line.
So as much of a marvel as this is, there are absolute boundaries in medicine. We have to clearly establish the uncompromising safety limits of this procedure. Desensitization is strictly, unconditionally forbidden for patients who have experienced SCARs, which stands for Severe Cutaneous Adverse Reactions. These are delayed type 4 immune reactions driven by T cells that result in devastating, totally life-threatening skin and systemic damage. We're talking about conditions like Stevens-Johnson syndrome, toxic epidermal necrolysis, DRESS, and AGP. For these phenotypes, the procedure is never indicated, because even minute sub-threshold amounts of the medication can trigger catastrophic, irreversible tissue damage.
And it's not just scars. Type 2 cytotoxic reactions, type 3 immune complex reactions, drug-induced vasculitis, Kuhn syndrome, and Takotsubo cardiomyopathy are all absolute contraindications as well. If a patient exhibits these specific endotypes, that culprit drug must be avoided entirely. The immune system in these very specific scenarios just cannot be safely hacked by rapid dose escalation.
So, why does all this matter? Simply put, when executed correctly on the right clinical phenotypes, drug desensitization quite literally saves lives. Mastering these protocols ensures that essential first-line treatments, whether it's a targeted monoclonal antibody for a rare autoimmune disease, a platinum-based chemotherapy for cancer, or just an irreplaceable antibiotic, are kept right on track, drastically improving a patient's prognosis. But here's a wild thought to leave you with. This whole process, it doesn't cure the allergy, it doesn't create permanent tolerance, it merely pries open a temporary window of safety that slams shut as soon as the drug leaves the patient's system. It has to be repeated with every single exposure. So as medical science advances and our targeted biological therapies grow ever more complex, the big challenge remains: how are we going to continue to refine these protocols to safely outsmart our own immune systems? It's a fascinating frontier in immunology and one that is definitely going to keep evolving. Thanks for joining me on this explainer, Focused Learners. Keep asking questions and keep exploring the science.